Welcome to this edition of ECG 5-Minute Consult, brought to you by myself, Bill Hayden, co-author of ECG for First Responders, available at Amazon.com. ECG 5-Minute Consult highlights 10 potentially lethal ECG diagnoses that may go unrecognized. So far we have reviewed the following cases: Wellen syndrome, digoxin toxicity, pulseless ventricular tachycardia, cardiac tamponade, long QT syndrome, and de Winter's T-wave. Paramedics respond to a daughter's call for her 53-year-old mother who was found semi-comatose at home. She reports that her mother has had chronic pain due to recurrent migraines. Her headaches have become more frequent over the past 2 months. She has become increasingly depressed because of pain. Medications include amitriptyline for chronic pain and depression. There is no history of nicotine, alcohol, or recreational drug use. Her past medical history is otherwise unremarkable. On physical examination, she is difficult to arouse, responding only to pain stimulus. Her Glasgow Coma score is 10. Stat glucose reading is 110 milligrams per deciliter. Her pupils are mildly dilated with sluggish reaction to light. Blood pressure is 160/90, heart rate 110, respirations 20 per minute, and pulse oximetry is 95% on room air. Her temperature is 99 degrees Fahrenheit and her skin appears flushed. Her chest is clear to auscultation. On cardiac examination, there is a regular rhythm with no murmurs or extra sounds. On examination of her abdomen, she has hypoactive bowel sounds with mild abdominal distension. This is her 12-lead ECG. You may pause the video for closer inspection. Let's use the primary survey to analyze this ECG. The ECG primary survey is a method to quickly identify potentially life-threatening emergencies on ECG. The primary survey addresses these 5 elements: heart rate, heart rhythm, ST segments, T waves, and other findings that suggest occlusive myocardial infarction. The first element is heart rate. Is the heart rate so fast, tachycardia, or so slow, bradycardia, that this rate is causing chest pain, altered mental status, shortness of breath, shock, hypotension, or heart failure, findings that suggest cardiac instability? You can estimate most heart rates by applying the 300, 150, 100, 75, 60, 50 sequence rule. On the rhythm strip, start where a QRS lands on a small box grid line, red arrow. If the next QRS lands on the next small box grid line, the rate is 300 beats per minute. Or should the next QRS from the starting point land on the second small box grid line, the rate is 150 beats per minute. You can also estimate rate by counting the number of QRS complexes that occur in 6 seconds, that is 30 large boxes, and multiplying by 10. Our patient's heart rate is 110 beats per minute. She has no signs of cardiac instability such as chest pain, shortness of breath, shock, heart failure, or hypotension. She does have altered mental status, but a heart rate of 110 should not cause mental status changes. The second element of the primary survey is heart rhythm. Is the rhythm supraventricular or ventricular? To determine whether the rhythm is supraventricular or ventricular, examine the QRS. If QRS intervals are less than or equal to 3 of the smallest boxes on the ECG grid, the rhythm is presumed supraventricular in origin. Supraventricular rhythms tend to be stable unless prolonged. This is a supraventricular rhythm since the QRS measures no more than 3 of the smallest boxes on the ECG grid. If the QRS interval is greater than 3 small boxes with no associated or discernible P waves, the rhythm is presumed ventricular. P waves can be seen here in V2 red arrows. Ventricular rhythms are unstable and may deteriorate into ventricular tachycardia or ventricular fibrillation. The third element of the primary survey is ST segments. Are ST segments consistent with ST elevation myocardial infarction, STEMI, or non-ST elevation myocardial infarction, NSTEMI? In this patient's ECG, ST segments are not elevated. However, there is diffuse ST segment depression below the baseline or isoelectric line. ST segment depression may appear upward sloping, as seen here by the red arrows, downward sloping, or horizontal. Downward or horizontal sloping of contiguous ST segments is more suggestive of ischemia or possible NSTEMI. In such cases, elevated troponin T will confirm non-ST elevation myocardial infarction. Other causes of ST segment depression include hypokalemia, left bundle branch block, and medications such as digoxin. The primary survey shows no definitive signs of STEMI or NSTEMI. However, signs or symptoms of coronary artery occlusion may be present in the absence of ECG findings. Remember that a normal ECG does not rule out acute coronary syndromes. However, in this case, the patient's history and clinical presentation make coronary artery occlusion less likely. Examining T waves is the fourth element of the primary survey. When present, are T waves consistent with occlusive myocardial infarction? T waves are positive deflections following each QRS complex and may represent ventricular repolarization. T waves are normally upright in all leads except AVR and variable in leads 3 and V1. T waves in early occlusive myocardial infarction, or STEMI, appear tall, wide, and asymmetrically peaked, so-called hyperacute T waves. In NSTEMI, T waves may appear flat or inverted following ST segment depression. Tall, narrow, symmetrically peaked T waves are characteristically seen in hyperkalemia. Although these T waves appear unusually broad, they do not suggest occlusive myocardial infarction. Given this patient's history and physical examination, which of the following most likely explains the ECG findings from your primary survey? High serum potassium, myocardial ischemia, drug toxicity, atrial flutter, or normal ECG? The correct answer is drug toxicity. Recall this patient's medical history. Her medications include amitriptyline for chronic pain and depression. Always regard any medication as a potential toxin. Amitriptyline, Elavil, is a tricyclic antidepressant drug prescribed for various disorders, including major depression, chronic pain, and migraine prophylaxis. Other tricyclic antidepressants are listed below, including their generic and brand names. The diagnosis of TCA poisoning is primarily based on clinical findings. This may include a history of ingestion, symptoms and signs consistent with the diagnosis, and characteristic ECG findings. Tricyclic antidepressants work by inhibiting the reuptake of neurotransmitters such as serotonin and norepinephrine, which can modulate mood. Tricyclic antidepressants may cause more significant adverse effects due to their anticholinergic activity and lower threshold for overdose. TCA anticholinergic effects in overdose include biochemical effects with acetylcholine blockade at cholinergic receptor sites and clinical signs of acetylcholine blockade. These include hyperthermia, dry as a bone, flushing, red as a beet, dilated pupils, blind as a bat, sedation and delirium, mad as a hatter, and intestinal ileus and urinary retention, full as a flask. TCA overdose may also cause alpha-1 adrenergic receptor blockade, resulting in orthostatic hypotension and dizziness. TCA overdose may also result in H1 histamine receptor blockade. This may produce sedation, increased appetite, weight gain, and confusion. ECG effects in TCA overdose may include the following: tachycardia, R wave greater than 3 millimeters in AVR, with deep and slurred S waves in leads 1 and AVL. There is prolonged PR and QT intervals. If the QRS in lead 2 is greater than 100 milliseconds, there is a risk for seizures. If the QRS is greater than 160 milliseconds, there is a risk for both ventricular tachycardia or fibrillation. And finally, there may be nonspecific or broad T-wave changes. Treatment of TCA overdose may include the following measures. Always follow local protocols. Airway, manage as necessary, which may require an advanced airway. Breathing, provide supplemental oxygen. Circulation, support with boluses of isotonic crystalloid and, if necessary, vasopressors such as neosynephrine or norepinephrine. Treat ECG conduction disturbances with intravenous sodium bicarbonate per protocols. Seizures, treat with benzodiazepines per protocol. And for GI decontamination, use activated charcoal per protocol if within 2 hours of ingestion. This case featured a 53-year-old victim with TCA overdose, consistent with her medication history and characteristic physical findings. Her ECG was abnormal with tachycardia, upward sloping ST segments, and broad T waves. TCA overdose is a diagnosis you do not want to miss. ECG for first responders will boost your skill and confidence in ECG interpretation. ECG for first responders is available at Amazon.com.